My name's Todd Leedy. I'm the Associate Director of the Center for African Studies, and I'm just going to welcome everyone briefly and lay out the parameters since this is a new mode of delivery for us for Barazas. First of all, this is a historic day in the sense that this is probably going to be the largest Baraza that's ever been held at the University of Florida. Even though there's only 2 of us in Grinter Hall at the moment, we have about 120 people registered for this event, which is well over our normal. So I'm just going to lay out the parameters for how the webinar will work, and then I'll turn it over to Professor Brenda Chalfin, who will actually introduce our speaker today. The Baraza speaker will go from anywhere between 30 to 45 minutes, and after that we'll do Q&A. And the way we're going to do the Q&A is you need to raise your hand, and then I will unmute you in the webinar function. And I'll take those in the order that they come. Please, we're not going to stop in the middle of the talk to answer questions. So raise your hand only at the end, and I'll take them in the order that they come. If somebody actually asks the same question that you're going to answer, I'd request that you unraise your hand so I don't call on you in any case. We do have a lot of participants. We have a limited amount of time, so please keep your questions brief. We will end promptly at 5 o'clock, but if you're still interested in having more conversations with our guest today, we will have a live Q&A on Twitter at Africa_UF for about 30 minutes with our guest today, so you can join us there after the session today. So now I'm going to ask Professor Brenda Chalfin to introduce our speaker.
Good afternoon, everyone. Welcome. This is an unprecedented format for us, and we're thrilled to have so many participants. Our speaker today is Professor Matiangai Sirleaf from University of Maryland, College Park College of Law, where she is the Nathan Patz Professor of Law. She holds a JD from the Yale School of Law, as well as a degree in international affairs from University of Ghana. Her areas of specialization are international law, human rights law, issues of health, and social justice. Her areas of specialization are quite broad. She's been working on epidemics for some time. She also has important articles on trafficking of hazardous wastes in Africa and international responsibility around epidemics such as Ebola. Her talk today is titled Africa, COVID-19 and Responsibility. Welcome to the University of Florida. We're really pleased to have you with us, even from afar.
Thanks so much for that kind introduction. And just one note, I'm at the University of Maryland, Baltimore, which is where all the professional schools are. Most of the professional schools in the University of Maryland system are located at the law school. So there, and then my name is Matiangai Sirleaf, and I'm really, really pleased to be here with you all today, talking about Africa, talking about COVID-19, and talking about responsibility. And while I cannot see you, I've been told that there are a number of you who registered, and so I'm excited to be in conversation with you. And I think that the fact that we are meeting remotely pretty much captures how drastically COVID-19 has changed our world. The coronavirus disease has also inverted stereotypical colonial narratives of disease directionality. For example, how could it be that the United States, where I'm resident and a number of you may be resident, is the pandemic epicenter? How could it be that over 30 countries have placed broad travel bans on travelers from the United States? An administration that has been notorious for increasing the racialization of borders in the United States, from the Muslim ban to the recent expansion of the travel ban to include a number of countries, including Burma, Eritrea, Kyrgyzstan, Nigeria, Sudan, and Tanzania. now has to contend with what it perceives as quote unquote shithole countries in the global south imposing travel bans on its residents. And so my talk today is going to draw on some of the persistent settler colonial conventions and narrative that we've seen with COVID-19, which have sought to map illness and disease onto racialized peoples and onto certain geographic regions, and in particular, the continent of Africa, with historical images of Black African bodies as uncontainable, as disease-ridden. This has resurfaced during the COVID-19 pandemic. And we see this in particular on the African continent because prior to the first reported case coming from the African continent, several media outlets demanded to know why it was that Africans were not presenting with the coronavirus disease. And even now, after there have been a number of cases coming from the continent or recorded on the continent, still multiple media reports have a seeming obsession with understanding the comparatively low COVID-19 numbers on the African continent as contrasted with other regions. And this harkens back to sort of the historical ways in which Black bodies in particular have been racialized as diseased. And so given that the African continent has so many Black bodies resident on it, how could it be then that COVID-19 isn't completely ravaging the continent? And what a conundrum this presents for some. And so the COVID-19 pandemic is definitely still evolving on the African continent. Thus far, it seems that many countries have been spared the worst in terms of comparative numbers, right? The African countries are not sitting at the epicenter of the pandemic as of yet. That said, or at all, really. But that said, the United Nations Economic Commission for Africa earlier this year released a report indicating that anywhere between 300,000 and 3.3 million African people could lose their lives as a direct result of COVID-19. And that in and of itself is significant because it depends on what the intervention measures are that are taken to stop the spread of the pandemic on the continent. And so the latest Africa Centers for Disease Control and Prevention numbers reveal that over 1,330,610 COVID cases have been confirmed across the African continent, with about 32,132 deaths and over 1,069,289 recoveries as of September 10th. So almost about as many COVID cases that we've seen across the African continent have resulted in recoveries. And so this contributes to the seeming obsession with what it is and how folks can fit into extant paradigms, how the trajectory of the pandemic is happening across the African continent. And of course, the numbers that are recorded or reported are only reflective of the robustness of the testing regime, and they may not be indicative of the actual number of infections. And so it's not the case that the numbers necessarily represent the actual state of COVID-19 on the continent, but they give us some indication at least of what the reported cases are. And from what we know thus far, the cases are geographically clustered predominantly in South Africa or in Northern African countries. As of yesterday, South Africa reported the highest numbers at 644,400 cases, while Egypt was at the second highest at 100,600, followed by Morocco at 79,800, and Ethiopia reporting over 62,000 cases. And so I wanted to give this background on where we are today with COVID-19 in and across different African countries as a way to lead into what I hope to focus my remarks on today. which is discussing some of the challenges and opportunities presented by COVID-19 on the African continent. In particular, I want to focus on the historical role of international financial institutions in limiting domestic health spending and capacity and contributing to systemic healthcare vulnerabilities across the continent. Additionally, I want to contextualize the response to COVID-19 vaccine trials on the African continent and the current race for vaccines. And then lastly, I'm going to address the need to reconceptualize responsibility for pandemic and epidemic diseases, drawing on some of my prior work. And so the challenges are there, and there is a cause for genuine anxiety, not fueled by sort of racist notions of diseased peoples. But there is concern, genuine concern about what the course of the pandemic could be on the African continent, because there are a number of pre-existing health conditions that could complicate the course of COVID-19 across different African countries. And that would make a bad situation worse in terms of health outcomes with COVID-19, because we know that with COVID-19, if you have a comorbidity, that can make your experience with COVID-19 more severe and also more deadly, depending on the type of prior disease exposure or disease exposure that you have at that particular time. And so given the prevalence of certain things like HIV and AIDS in sub-Saharan Africa, for example, in 2018, an estimated 25.6 million people were living with HIV and AIDS. There's concerns about COVID-19 coexisting with things like malaria, tuberculosis, yellow fever, and other communicable diseases. And that makes the potential of COVID-19 gaining momentum across the continent especially dangerous. And so I don't want to understate that. The other reason for concern about the trajectory of the pandemic across the continent is that there are a number of vulnerabilities that exist in the health infrastructure across the continent, where there are not enough provision of ventilators across the continent, such that if people are in need of critical care, we do not have similar critical care ventilation materials that we would need to be able to sustain people at sort of the worst spaces in the life of a COVID cycle in a patient. For example, in Burkina Faso, there are 11 ventilators for a population of 20.9 million. In Sierra Leone, there are 13 ventilators for a population of 7.9 million. In the Central African Republic, there are 3 ventilators for a population of 4.8 million. And in Somalia, there are 15 ICU beds for a population of 15.8 million. And so to the extent that capacity constraints become overwhelmed during the pandemic, this can present a huge problem, as there is not currently domestic surge capacity to withstand sort of an overrun on the hospitals. There are also a number of opportunities. I'm going to come back to the capacity constraints, but I also want to talk a little bit about some of the opportunities that are presented by this disease, if we can think about that in that way. There are a number of factors that weigh in the continent's favor, which have been pointed to a number of factors, including the relatively young age of the population, with more than half below 20 years old. And of course, youth doesn't immunize anybody against the disease, but it could mean that where COVID-19 presents, it's more mild or moderate. And there is somewhat less international travel between cities in the region via air, railway, or bus, as contrasted with other regions, which might slow down community transmission once it begins, or if it begins in earnest. There is, of course, the opportunity to draw on the resilience, creativity, and innovation that exists in African societies. For example, we've seen a number of African countries innovate, with Senegal developing $1 rapid testing kits. In Chad, we have town criers helping disseminate information about COVID-19 to rural areas. And in Kenya, textile factories have transitioned to mask making. We've also seen some leaders not making the most innovative or progressive steps with respect to COVID-19 in terms of playing on myths about how COVID-19 can be prevented, and relying on sort of non-scientific means for preventing the spread of the disease. That said, the experience that a number of African countries have had dealing with recent epidemics and disease outbreaks, from Ebola to, say, for example, Lassa fever, have also positioned African countries to be in a place where they can draw on lessons learned regarding, rapidly tracking down individuals, screening, and isolating potentially affected people. A number of airports already have had the infrastructure in place to screen for temperature and the like. In Nigeria, for example, there has been lab capacity that's been built up as a result of the Lassa fever outbreak. And so there are ways in which African countries are positioned to take advantage of the prior knowledge in dealing with disease outbreaks in ways perhaps that other spaces might not be as well positioned. There's also somewhat of a benefit of being the continent that has one of the fewest least amount of spread of COVID-19, because you're able to sort of learn from others and learn from others' mistakes and know what not to do. And so that opportunity and lead time to prepare a proactive response, to draw on knowledge and expertise that's local, is all incredibly valuable. That said, it's important that African countries simply don't sort of copy and paste things that are done elsewhere in a rigid fashion, because they might not make sense for the particular context that some societies are in. For example, much of employment takes place in the informal sector in a number of countries. And so this makes working at home in a posit for many. And so strategies that are based solely on stay-at-home orders, which presume the privilege and the ability to maintain social distancing, might not be achievable and might not actually make sense, particularly where people are living in crowded dwellings, in densely populated areas, in urban areas, or in informal settlements or slum areas. And so isolation strategies that are based on privilege, in fact, and wealth and resources and the ability to sort of safely distance oneself might not translate so easily in a number of places. In addition, isolation strategies that don't take into account acute challenges of needing access to clean water, limitations in inadequate sanitation, the lack of reliable electricity in a number of places, those things present health risks as well. And we've seen countries rise to the task by utilizing something called the Veronica bucket that was invented by Veronica Beko, who's a Ghanaian public health official during the Ebola epidemic. And this is effectively a mini hand washing station. That's a bucket and basin that is placed in public areas on top of a wooden stand. And it accounts for the inaccessibility of quick and easy sanitation in a number of places. And so we need to think about containment strategies that are as flexible and sensitive to local conditions along the lines of the Veronica bucket. And much of the strategies that have been followed elsewhere have aimed at flattening the curve, assuming that there is some minimal level of healthcare capacity to respond to the initial shock of increased demand for intensive care and other hospital resources during the pandemic. And so, as I said earlier, while in much of the world, the strategy has been to try to draw out the timeline of the pandemic so that everybody who needs critical care can get it, unless and until there is a robust vaccination and treatment regime in place, the capacity constraints of health systems in many countries may not be able to withstand an initial domestic surge in demand. And so that has to be taken into account when thinking about what the most effective public health strategy is in different African countries. That combined with some notoriously weak healthcare systems in some countries has meant that it's common for government officials and others to sort of go overseas to seek medical care in other African countries sometimes, for example, Ghana or South Africa, or sometimes they travel to India or Europe and the United States. And so what has been interesting to observe is that given the spate of border closures and travel bans that have been put in place as a result of COVID-19, that has effectively closed off the option of traveling abroad for a large swath of the elite. And so they must now contend with the fragile health systems and informal networks of care that the rest of their populations have depended on. And so this might generate interest or renewed interest then in trying to build up healthcare systems because the exit option for the elite politicians and well-to-do has been limited significantly with the COVID-19 pandemic. For example, in 2001, underneath the auspices of the African Union, a number of countries pledged to allocate at least 15% of their budget to the health sector each year. 2 decades since then, health investment in most countries is lagging significantly behind, and inadequate health spending across the continent is something that is a huge problem when you think about just endemic diseases, but certainly when you think about epidemic and pandemic diseases. Now, I want to connect the inadequate health spending to the substantial amount of money that a number of African countries have historically had to pay to service debts. And I want to turn now to talking about the role of international financial institutions in facilitating systemic healthcare vulnerabilities. And so briefly, I want to turn attention to the International Monetary Fund and other actors that provided loans, which encouraged the quote unquote structural adjustment of an economy as a condition for extending and refinancing debt. These austerity measures included things like cutting the budget deficit, improving the balance of payments, and countries accomplished this through establishing budget ceilings, wage caps, or reductions in wages in the public sector. And these restrictions on wages in the public sector that the IMF and others imposed meant that countries had limited money to employ and adequately remunerate doctors, nurses, and other healthcare professionals in the public health system. And so as healthcare employment opportunities lessened, healthcare quality also was impacted, and the healthcare workforce decreased. This was influenced in part by the limitation on wages within the public health system, which contributed to the brain drain problem in the health sector. So you had indigenous talent leaving for greener, more prosperous and profitable pastures. And so what happened is that the IMF prioritized short-term economic objectives over long-term investments in public health. And this predictably hollowed out the health sector, the public health sector, in a number of places. Now, it's of course impossible to isolate the impact of structural adjustment policies from other variables. but it seems that we can at least say that the reform policies were a substantial factor in producing weaker health care infrastructure. Some studies have shown that IMF policies have slowed down improvements in or worsened the health status of people in countries implementing them. Additionally, an independent evaluation of the IMF loan program surveyed 29 countries in sub-Saharan Africa between 1999 and 2005, and found that 37% of all annual aid increases were diverted to beefing up currency reserves, with another 37% going to repay debts in line with the dictates of structural adjustment. And so that left only 27% for not just health, but all other social and developmental needs. And so of course, causation does not equal causality, but this report and these studies indicate that the cumulative effects of the structural adjustment programs likely detrimentally impacted health systems in several African countries. And a case study of this is the subregion, the West African subregion, during the Ebola crisis, the first one that took place, the most recent one that took place in West Africa between 2014 and 2016, where you had the IMF belatedly recognizing the connection between its policies and the outbreak. IMF Director Christine Lagarde observed at a meeting on the epidemic that it's actually good to increase the fiscal deficit when it's a matter of curing the people or taking the precautions to actually try to contain the disease. And that the IMF doesn't say that very often. In fact, the IMF had been saying the exact opposite for years prior to the epidemic. And so now with COVID-19, it appears that history is again repeating itself. And you have actors like the G20 deciding to temporarily freeze the debt of 40 African countries in order to free up funds for countries to be able to more effectively respond to the pandemic. And so what I would submit is that they sort of after the fact, after you're already in the midst of an Ebola, or you're already in the midst of grappling with COVID-19, is not the time to build up a robust health system, right? A health system has to be in place prior to the shock, not setting up one during the midst of the shock to the health system. And there have been calls from a number of African leaders, for example, to create a global fund to prevent the collapse of health systems across the continent, with a facility that would perhaps provide budgetary support to flailing systems. There's also been a response from the African Union to formulate a continental-wide response to COVID-19. And the Africa CDC has established an Africa Task Force for Coronavirus that's supposed to be assisting countries with strengthening and building their technical capacities. And so those efforts are ongoing. I want to turn now to discussing vaccines and the challenges with vaccine trials on the continent, and what access may look like or not look like for populations on the continent. And so recently, a televised conversation between two French doctors went viral because of their comments discussing potentially utilizing experimental trials for a tuberculosis vaccine as an antidote to the novel coronavirus. And the John Paul Mira, who's the head of the intensive care unit at the Cochin Hospital in Paris, in April of this year, said, it may be provocative, but shouldn't we do the study in Africa where there are no masks, no treatment, no resuscitation? A bit like some studies on AIDS, where among prostitutes, we try things because they're exposed and they don't protect themselves. What do you think? Camille Locht, the research director at the French Institute of Health and Medical Research, responded, "You're right, we're thinking in parallel to study in Africa precisely to make the same type of approach. I think there's a call for tenders that was released or that will be released." And the fallout from this conversation was fairly swift. You had a number of actors responding quite forcefully against these types of remarks, namely Tedros Ghebreyesus, the Director General of the World Health Organization, denounced these kinds of racist remarks as a hangover from a colonial mentality. The fallout on social media was similarly swift, with Didier Drogba, a football star from Cote d'Ivoire, commenting that Africa isn't a testing lab, and Samuel Eto'o, a Cameroonian football legend, stating "des assassins." And so this dialogue between the doctors and the strong reactions to their statements reopened wounds of Black, Indigenous, and other people of color being treated as disposable, and their bodies being treated as disposable. In late June of this year, when the University of Oxford announced that it would begin a new trial of its COVID-19 vaccine in Johannesburg, this was met with protesters challenging the trials as using African people as quote unquote guinea pigs. Now, the conventional wisdom is to treat these instances as sort of uninformed or irrational responses in the face of a public health emergency. In these remarks, I want to situate the resistance of Black Africans as informed by years of historical, unethical human experimentation that has been carried out on Black and other people of color that continues to this day. And so experimental trials have been increasingly outsourced to the periphery, with many of them taking place on the African continent without adequate legal frameworks in place to regulate abuses. In 1996, during the worst ever meningitis outbreak in Africa, you had Pfizer conducting a clinical trial in which 100 children in Nigeria were given an experimental oral antibiotic called Trovin, while a further 100 received cifetraxone. 5 children died on the former and 6 on the latter. Some children allegedly received a dose lower than recommended, leaving many children with brain damage, paralysis, or slurred speech. The parents of the children sued Pfizer for failure to obtain informed consent, and Pfizer settled the suit after a protracted 15-year legal battle. GlaxoSmithKline also supported suspect clinical trials in Uganda between 1997 and 2003, which led to thousands of serious adverse effects for women taking the anti-HIV transmission drug Nevirapine. Their symptoms went unreported, but testing continued and resulted in the deaths of 14 of these women. More recently, in December of 2016, during the height of the Ebola epidemic that took place in Liberia, Sierra Leone, and Guinea, the World Health Organization reported that an experimental vaccine proved promising against Ebola, as in a major trial in Guinea. And you had the assistant director for the World Health Organization remarking that, while the compelling vaccine results come too late for those who had lost their lives during the epidemic of Ebola, the 2014 to 2015 Ebola epidemic, they show that when the next outbreak hits, we will not be defenseless. As you all may very well know, the epidemic of Ebola taking place in the DRC and the like has not proven that to be the case. And so contrary then to this narrative, local and global inequalities mean that the fruits of medical and scientific advances are stockpiled for some and denied to others. And during the 2014 to 2015 Ebola crisis, you had an Italian NGO testing amiodarone, which is a heart drug, on Ebola patients at a treatment facility in Sierra Leone. The drug is not among the 53 drugs listed to have an antiviral effect on Ebola, and led some British medics working at the center at the time to conclude that the side effects from the drug could be contributing to increased morbidity within the center, leading a number of medical staff to walk out of the facility because of the lack of informed consent obtained from patients, and because they were using a drug outside of a clinical trial. Relatedly, thousands of blood samples were taken from Ebola patients during the 2014 to 2016 epidemic in West Africa. And those blood samples are being held in laboratories around the world. Ebola survivors did not consent for the blood to be taken. Several African scientists have accused the laboratories of essentially biological asset stripping as they are unable to access them for their own research, despite African health practitioners assuming all of the risk in drawing the blood. And so I wanted to spend considerable time talking about this because it's important to contextualize the response to COVID-19 trials and the introduction of these trials in a number of different African countries, because the history, recent history actually, of experimentation is not sufficiently widely known. And although ethicists, medical professionals, and legal commentators have questioned the practice of using experimental treatments on African subjects, even in clinical trials, especially where protocols require the withholding of critical information and therapy from individuals who are selected as controls because of vulnerabilities that exist and because of the lack of a robust monitoring mechanism either at the national level and certainly at the international level. Generally, the World Medical Association's Declaration of Helsinki and the World Health Organization's Good Clinical Practice Guidelines are supposed to provide protection, but in the cases that I have just discussed, they provided very limited, if not any protection to the rights and welfare of those study participants. And so the lack of robust monitoring mechanisms in international law then helps to sustain a very problematic trend of medical neocolonialism on the African continent and elsewhere. And I use the term medical neocolonialism to characterize the pattern of extraction of resources from people of color for experimental clinical trials, when the knowledge generated from this research is taken to develop new treatments and drugs for the benefit of others elsewhere. And the subjects of the research in the communities generally do not share equitably in the benefits of the new drugs or treatments. And so medical neocolonialism then is akin to the characteristics of historical colonialism, in that medical neocolonialism is similarly driven by economic dependence, exploitation and inequality, and treating communities of color as disposable. And so where is the solidarity then in this race for a vaccine? As you may know, the United States has decided to not take part in the global effort towards finding a reliable COVID-19 vaccine. A number of countries that are taking part in the global effort are also simultaneously having bilateral agreements and side agreements that they're drafting to protect their populations first. And so whenever it is that a reliable vaccine for COVID is developed, how is this vaccine going to be distributed around the world? How will it be done in an equitable manner? And where will African countries be positioned in this global race for a vaccine? As Chikwe Ikwazu, the Director General of the Nigeria Center for the Disease Control, commented, if we say that we're living in a global village, and health security is everybody's problem, then why are we not developing our response with this notion in place? You can't say that global health security is everybody's problem, yet within the global system, access to diagnostics, access to therapeutics, access to vaccines is managed through a pathway that limits the access to parts of the world, because inevitably we put ourselves collectively at risk. And so I think there needs to be a whole thinking about health security that has to change. The concept of every country trying to look only within its borders is completely mind-boggling and is a waste of everybody's time. Yet we see that happening right now with the race for COVID-19 vaccine, and even sort of the hesitancy to say how different regions and populations will be prioritized in terms of access to that vaccine whenever it is developed. And so one of the things I wanted to then end with is how might we think about responsibility and differentiating responsibility to recognize special situations of need for epidemic and pandemic diseases. How might we assign greater responsibility to those who have contributed more to an epidemic, or assign greater responsibility to those who have resources or capacity to deal with an epidemic? And COVID-19 makes thinking about responsibility for pandemics especially important. And so I've done work in this area to try to develop both a normative justification for a responsibility for pandemics framework, but also a legal framework for relying on the common but differentiated principle in international environmental law to tease out some of this. And so morally, we can think about this as pretty straightforward. We have a responsibility to help those that are in need. And so we need to differentiate based on relative health needs, because public health risks are not distributed equally. And COVID-19 has demonstrated quite vividly that some countries are going to be more needful of assistance than others. Some are going to be more vulnerable than others, and there's a need to help those in a way that is sharing responsibilities, but also one that takes into account capacity, right? So if we are interested in effectively combating highly infectious diseases, then how do we allocate responsibility in a way that allows those with the most capacity to do so? And how do we think about relative capacity to respond to a given pandemic? So it may be more socially desirable to have not those with the most capabilities acting, but those who have relative capability acting, because of the fear of those that have the most capability reifying geopolitical hierarchies in ways that allow powerful actors in the international system to exercise even more leverage over countries in the global south. And then the last aspect is sort of thinking through broadening notions of culpability beyond extant legal frameworks, but drawing on global public health, international human rights law, and a number of other bodies of law to try to think through how we can think about elongating the culpability gaze such that it's not just sort of the immediately preceding acts of a pandemic that are considered, but the causation inquiry is broadened to take into account actions and omissions historically that have been substantial factors in producing or contributing to serious adverse consequences witnessed during an epidemic, or that have created and facilitated vulnerabilities in health systems. And such a framework, I think, would not leave countries solely responsible for addressing adverse events experienced by pandemic and epidemic diseases on their own, particularly when a number of the vulnerabilities that exist in health systems is because of structural conditions within the international system. And so thinking more seriously about the role of historical responsibility is something that is necessary. And I think that I will conclude by just saying, the COVID-19 pandemic has rapidly changed the world as we know it. And it has created a world in which few had previously envisioned. And so I think that that means that there is also an opportunity then to harness a potential, the potential opening created by COVID-19 to create a more just world order. So I'll end my remarks there and then take any questions that you guys might have.
Thank you, Professor Sirleaf. I'm going to take these in the order that I get them. Octavio Gomez, so yeah, you're up. Your question for the professor.
Yeah, I had a quick question. In the United States, the calculation for excess mortality kind of accounts for 80,000 additional deaths that aren't directly attributed to COVID, but based on the metric, can kind of secondarily be attributed to its effects, potentially, diseases of despair and things of that nature. I was just thinking if there are metrics like the excess metrics, excess mortality metric in throughout the African continent, and other indicators that could better inform us about how COVID itself, and not just the mortality impacts, but also like economic impacts, social impacts that's happening across the continent, if there's anything in that nature.
Sure. Thank you for that question. So I think that there are some challenges. Well, there are a lot of challenges presented by trying to paint an accurate picture of what is actually happening with COVID-19, and we know that from the experience here in the United States and elsewhere, right? So we know that here, even the estimates that we have of the number of cases are not representative in the United States, because it's only indicative of those who have gone to test. And so we've been advised by public health experts that the numbers are much more than what's reported. And so we know that to be the case elsewhere as well. And the challenge, I think, that's presented in a number of African countries is that some of the things, and in the same way that, say here, initially, there was, more flu deaths or something like that being reported, or where there's not sufficient testing capacity, the deaths are being recorded as something else. So that is something that could be happening as well in a number of different countries, where the deaths are being attributed to some other disease that's more familiar than COVID-19. And so that might be explaining somewhat the numbers. But in terms of the social and economic impact, there's diseases of despair and the ways in which that measures. It would be hard to know how the diseases of despair, how to isolate diseases of despair as sort of directly attributable to COVID-19, as opposed to diseases of despair presenting because of other confounding or coexisting diseases. And so that would, I think, be difficult to measure in a number of places on the continent. But we are aware generally of what the economic impact is from the slowdown globally that COVID-19 has caused. And so even though the numbers that we have don't indicate sort of a severe pandemic in terms of at least deaths in a number of African countries, the economic and social impact has been quite dismal, because a number of countries were experiencing growth, were experiencing a number of positive things happening in their economies, and that has been forestalled somewhat because of the larger challenges that are taking place. The restriction in travel, which although is not supposed to impact trade, does impact trade. And so we know that that is having a detrimental impact as well. And I think that the sort of economic cost is still being measured across the continent, and the social cost is certainly still being measured. And so a lot of sort of accurate data on what exactly is happening and what the picture will be is developing, and I don't think that we can say affirmatively now what that is. Yeah.
Thank you. Anita Spring, you're next. Anita, are you there?
Yeah, oh, sorry, I'm muted. Can you hear me?
Yes, yes.
Yes.
Oh, okay. Thank you for a very comprehensive lecture. I really appreciate it. I want to comment that in addition to the young age of issue, in Africa. There's also the older people who are cared for at home, and there are no nursing homes. You know, in the US, a lot of the victims were in nursing homes and continue to be so. Also in Madagascar, they had a MMR, measles, mumps, and rubella campaign, and vaccinated 90% of the country. And people think there's some protection for serious cases as a result of that. And then in Rwanda, people who didn't distance and wear masks were made to go sit in all-night lectures in a football stadium, and I think something like 70,000 people had to go through that. But South Africa, for example, may be closer to the US, and I want to ask a question about, since you're a lawyer, about human rights and people, what they think about their rights issues. So I saw a lot of people in South Africa being very careful about social distancing and washing their hands and wearing masks, but then there were other people who didn't do that. And, you know, in the US, people think they have the right to not do any of these aspects that can help. So how would you put in like Nigeria, Ethiopia, and South Africa as people who might think that they don't want to do any of these things because they want to maintain their rights to do whatever they want to do?
That's a great question, and thanks for that comment as well. Certainly there is sort of informal networks of care that are routinely relied upon, in part because there isn't as much reliance on, as you said, nursing homes and other things like that to care for the elderly, so that you don't have a number of really old people necessarily all congregating in the same space and potentially co-infecting each other. So that's certainly something that has to be accounted for. I think that there is an interesting comparison to be made in thinking about rights as, and rights sort of in the context of particular societies. And so there's a way in which the African Charter for Human and People's Rights already, just in name, talks about rights and its conception of human rights in community with others, which is perhaps different than when you think about the Bill of Rights here in the United States, which has a more individualistic conceptualization. But even still, rights, human rights generally are not held in the absolute in the US or elsewhere. So irrespective of what people view or perceive their rights as absolute, that no right is held in absolute, meaning that rights can be restricted by the government given a interest that is for the general public, for the welfare of others, for protection of public order, for a number of other things in human rights law, which allow for rights to be limited. And so rights are contextual. They are held in relationship to others. Your right to something doesn't mean that you are able to impose or infringe upon another person's exercise of their right. And so I think that the way of thinking about rights on the African continent that's reflected in the African Charter, which is a more communitarian understanding of rights. Rights are situated in relationship to communities and in relationship to people, and to situates the individual sort of in society with a nexus to others, which means that your rights are not sort of rights to do whatever you want to do. It isn't a liberty right to do whatever you want to do, irrespective of whether it causes harm to your fellow person in that community. Here in the United States, there is, even though rights, again, are not held in the absolute, there is a conception that rights are held absolutely, and that you can exercise your rights irrespective of whether they infringe upon other people's rights or not. And that's not, I mean, that's not constitutional doctrine. That's not all of the doctrine that exists is about whether a governmental interference with the right is constitutional, whether it's too much infringement, or whether it's just enough infringement, and so on and so forth. And so in respect to thinking about rights and masking, there isn't a right to I don't want to take up too much space with this, but I know that it is something that is important, because I get asked this a lot. In the what is it that people are claiming a right to, in terms of the desire not to wear a mask? And if anything, it's a bodily integrity, autonomy to be able to decide what you do with your body, including your face. But again, your right to your bodily integrity and autonomy is not exercised in the absolute. It's tied to whether your exercise of autonomy is infringing upon other people. And so in the US and also in South Africa, you give the example of South Africa, your right to want to be free of a restriction of a mask, or what you perceive as a restriction of a mask, does not entitle you to go into a public space and demand that that right be exercised. Certainly you can say in the privacy of your own home, you have a right to not wear a mask. Okay, yeah, because of a number of other rights that come along with the protection of one's personal space, privacy, and the like. But you don't have the right to go into public spaces and demand that you be without a mask, right? And so that sense of an entitlement, I think is ill-informed, and I think it's also a very privileged way of thinking about the world and society, and the connections that we have to societies, and the responsibilities and obligations that we have to one another. I
was thinking the Africans do better than the Americans on this. Is what I'm.
I think
that's where I'm coming from.
I think that there's something to that, because I think, like I was saying, societally there is a less emphasis on sort of individual, qua individual, as like the governing order, right? There is, at least in some places and spaces, a more community focused upbringing that happens societally. And so that also informs how you understand your rights. Your rights are contextual, your rights are in relationship to others, and you recognize that in a number of different African countries, and that's recognized at a regional level, and it's recognized at a national level in a number of constitutions, where you see rights situated in community, where you don't necessarily see that, say, for example, in the US. So yeah, thank you.
I think the rate is lower.
Thanks for that.
Thank you. Abe Goldman, you're up.
Okay. Thank you very much. I really appreciated your talk and the fact that you were willing to, address this topic. And I'm struck by the role that leadership plays, obviously in the U.S. and across our states, but also across Africa. There have been some really notable cases of the complete denialism and abject failure of leadership to address the pandemic, probably Tanzania stands out for that as probably the most flagrant example. They've reported essentially 0 new cases in the last several months, and a total of about 500 cases, and Tanzania has over 60 million people. So I wonder if you'd comment on that. There are, I don't know what's happening on the ground in Tanzania, but their official statistics are ridiculous, and the President Magufuli has just taken an absolutely absurd position, more or less basically denying the reality of the pandemic. And As I said, he's probably the worst example, but he's probably not the only example of that. And I wonder if you'd comment on that a bit.
No, I mean, I think that the role of leadership cannot be overstated. I mean, I think we know that for those of who are situated in the U.S., just from this administration's sort of complete, I think, divorce from reality perspective, at least at the very top level, in terms of understanding the disease, in terms of the advice that's given, in terms of telling people to, drink bleach, telling people that the disease will be gone by April, telling people that the disease is just like the flu, telling people I mean, I don't want to give too much space to the number of not even mistruths, but just things that are just not at all accurate about the epidemic. And we've seen the ways in which in this country that has informed whether people think the coronavirus is a hoax, right? Whether the whole thing is made up by the Democrats, so to speak. And so that is, it is not then unsurprising that you would see other leaders in other places who are denying the role of COVID-19, the ways in which it's transmitted, and are also trying to not have the numbers accurately reflect what is happening with respect to the pandemic in their particular country. I mean, we've seen places in the United States where the CDC has changed its advisory in terms of telling people that are asymptomatic not to test. And so that is going to impact our numbers. We've seen the ways in which some deaths are being treated differently in terms of numbers, all with an eye towards electoral politics and other things that have nothing to do with protecting people's health. And so the Tanzanian example that you alluded to or reference is what I was thinking about when I was saying that there are a number of spaces where you do have leaders who are on the African continent who are talking about COVID-19 in ways that are divorced from reality, in ways that are not helpful at all, and are doing damage to the response, even just marshaling the political will to dedicate resources to dealing with the course of the pandemic, and also to in terms of just directing people to take this as something that's serious. And that is not, a made up thing or something that you can deal with simply through prayer or other things that have come out from the Tanzanian leader with respect to this particular pandemic. And it makes me think about the role of leadership also with another disease in the continent and elsewhere too, about the myths that surrounded HIV and AIDS. And the way in which Thabo Mbeki and others in South Africa initially downplayed the ways in which HIV and AIDS was transmitted, and frustrated public health efforts to try to stem the spread of HIV and AIDS within South Africa. And so I think that in any space where there is an epidemic disease that is happening, that is new, that is novel, there is the potential for leaders to mislead the public on how they should be responding to, how they should be protecting themselves from the disease, how governmental entities should be addressing the disease. And that can be for political reasons. It can be because people are more concerned about electoral politics. They don't want themselves to look bad, and so they cook the books, in other words. And so it's not, sadly, it's not surprising that you have instances like the Tanzanian president's comments with respect to COVID-19, because we've seen this before. Yeah.
Thank you. Am I still on? If you don't mind, I'd like to just make one other slight statistical observation. India has about the same population as sub-Saharan Africa as a whole, a bit over a billion people. And India currently reports about 4.5 million cases. And and it's climbing. You know, I'd very much like to be optimistic about the prospects in sub-Saharan Africa. But currently the number of cases, the population, relative to population in South Africa is higher than that in India. And, you know, if South Africa is any indication of what might happen in the rest of sub-Saharan Africa, 4.5 million is not out of the question as an eventual caseload.
Yeah, no, I don't think that there is reason for false optimism about the trajectory of the COVID-19 pandemic on the continent. I think that there is, and I addressed that there is real concern about the course that the pandemic can take. And the numbers that we have, again, are only an indication of the robustness of the testing regime. They don't tell us what the actual on the ground situation is with respect to COVID-19. And so there is real cause for concern about, you know, if and when we have a more accurate picture of the numbers and the spread of COVID-19. And also too, I'm worried about the sense that, oh, well, it's not so bad, and that there will be a laxity that happens because of the sort of lag in testing and reporting of test results, that will create a sense of false comfort. Whereas, you know, at the beginning of the pandemic, you had much more forceful efforts from different leaders of different countries. You might have them, you know, pulling back, as we've seen has happened in a number of spaces in the US, as if, you know, things are over, when it's like we're very far from being at the tail end of this pandemic. And so there is genuine cause for concern. So thank you for that comment.
Okay, Sarah Staub, you're up.
Okay, hi, thank you for your talk. I had a question, and it's somewhat related to the malaria vaccine, but I didn't know if there was kind of any discussion on the human rights or legal aspects of the responsibility of kind of drug manufacturers or drug trials that are currently going on to ensure that they aren't disrupted. And that's kind of specific to the malaria vaccine, as children are going to need the 4th dose in November, and if they miss that dose, their chances of getting severe malaria shoot up 44% than if they didn't get the vaccine at all. And that considering there's ethical implications around the implementation of that, mainly with the WHO was not requiring that participants in this drug pilot get informed consent.
So I don't want to, I do want to focus on COVID, so I will address this somewhat, but just tangentially. I understand that your interest is in malaria, which is of course important. I want to talk about malaria in the context of, you know, there being a number of diseases that are not pandemic, that are endemic, and they impact and may impact, like malaria, far more people that we know of to date, and that one of the challenges with pandemic diseases like COVID-19 and the like is that they can suck up all of the oxygen in the room in terms of funding, in terms of the attention span, in terms of resources, in terms of the focus of trials, whereas, as you mentioned, there might have been a lot of progress happening with malaria, but then now everybody's attention is now focused on COVID, and so that is derailing other efforts that are important and that are actually necessary too, because if you think about pandemic as sort of seismic shocks to a healthcare system, you have things that are ongoing shocks to a healthcare system that also need to be addressed. And so you need to be able to be doing both, not just taking resources from and attention from malaria trials and the like, and then focusing instead on COVID or the next emerging disease that emerges, because that is like a whack-a-mole public health strategy that doesn't actually help to create a robust health system or to create better health outcomes for people. And so in terms of the trial itself, I do not know what the state is with respect to legal challenges that have been posed or that might be posed for the failure to essentially follow up or continue through with the trials. I know that the guidelines say that follow-up is supposed to occur generally. What happens if follow-up doesn't happen, or what happens if the continuation of treatment doesn't happen, is something that is in somewhat dealt with on study by study basis. And I don't know enough about where things are with the malaria trial to speak any further than that, because I have not spent time looking at that particular protocol. But I appreciate your question and look forward to learning more about that.
Thank you.
Okay, Steve Brandt, you're up. Steve, are you there?
Yes, can you hear me now?
Yes.
Yes.
Okay, good. Well, I have a couple stories that are anecdotal, and they relate to Tanzania and Ethiopia, and what Abe was saying earlier. And that I just received an email from one of our former UF PhD students, Dr. Audax Mabula, who was director of the National Museums of Tanzania, and now professor at University of Dar es Salaam, saying that they had no aid, they had no COVID there. And he was hoping I was okay, but they're doing great. And he's taking a bunch of students to Olduvai Gorge next week, as if, you know, there's nothing going on. And then also in Ethiopia, the stories I get from my friends there are that it doesn't seem to be a big deal. The hospitals aren't overwhelmed. There are a few cases in places where you would expect horrible rampaging COVID in places where the people are really packed in together, and they're not. It's not spreading. So I really am puzzled, you know, by what's going on. I don't think anybody really has a handle on this.
So I think it's more a comment than a question, but that's fine.
Sure,
I was in faculty workshops, and so that's great. I mean, I think that what I can say, just reflecting on the comment, is that yeah, I think that there are questions that exist about what the scope of the pandemic is and isn't in different countries, and I think that the earlier concern that I raised with sort of the laxity that I fear might occur as a result of not seeing the immediate impact of COVID-19, potentially leading to maybe even more devastating results when the sort of reality of what is happening with the spread becomes more real, to the extent that it is spreading undetected. And there's just not enough test or testing or recording of cases. And so it is yet to be determined what the story of COVID will be on the continent. And I think that there are a number of research questions and actual sort of, you know, real life questions that exist as a result of the pandemic.
Thank you.
Okay, next up, Madeline Perez. Madeline? Madeline, are you there? Okay, we've lost Madeline, it seems. I'm going to move to the next hand. Agnes Leslie. Oh, Madeline is there. Okay.
Oh, I'm so sorry.
Okay, go ahead.
Hey, So I first just wanted to say that this is very new information to me. So I'm really grateful to be here and to hear your knowledge on it. My question was about when you mentioned earlier, way earlier, about the 2 French doctors that were wanting to do that experimental with using the TB vaccine to treat COVID. My question was if there are any legal constraints that I guess would stop foreign medical intervention from doing that, or because I know there's a big history of mistrust from Western medicine in African countries. So I was just wondering if there's anything that they can do to stop that intervention, or if it's just under the name of the UN that they can't really do anything about it. And I apologize if this question might have an obvious answer, this is all very new to me, so yeah.
No, all questions are fine. I think that, so underneath the different clinical guidelines, you are supposed to, use whatever, say an example of the tuberculosis vaccine that they think might have some benefits for dealing with COVID-19. You would need to develop a protocol that talks about what the risk would be to study participants, what the adverse events is what the term is called, would be, what the potential benefits, and then there is a determination made by an institutional review board that says whether the benefits outweigh the risk, or the risk outweigh the benefits, and where the generally where the benefits outweigh the risk, then the study is allowed to proceed, and where vice versa, then the study is not allowed to proceed. With emerging diseases, there are some laxing of protocols that allows for doing experimental testing sort of prior to testing being done in animals and the like, sort of expediting to go to human trials. And so the specific instance that the 2 doctors were talking about was just the potential of using a tuberculosis vaccine for dealing with COVID-19. They weren't talking about a particular study, but they were saying that there should be tenders, meaning that there should be protocols that do just that. The problem in that discussion was several, but one of the issues is that there is a way in which, as you alluded to, historically there has been a sense that people of color, particularly Black people, are sort of quote unquote usable, available, disposable bodies for trying to figure out whether this thing works with respect to advancing some medical goal or objective. And so the blowback from their statement came in large part to referencing the ways in which a number of problematic HIV/AIDS tests were done on the continent, which I referenced in my comments earlier. And so some of the response is informed by that sort of historical drawing on exploitative trials, where even though there is a protocol that says XYZ, this is what you're supposed to do, where there are adverse events that happen, they are not either properly recorded, or people are not fully informed about the risk that they are undertaking in a given study, or you might have a clinical trial, sort of a non-clinical trial setting where something is being tested, like for example, the heart drug that I mentioned that was being used on Ebola patients outside of a clinical context. And so that is something that is not allowed legally, but of course it's something that was happening. And so we know that there are many places where it's not just a matter of the law dictating X or dictating Y, the reality or the practice might be happening in contravention or outside of what the protocol requires or stipulates. And so it depends on what is happening in any given trial as to whether it comports with what is legally required.
Thank you.
Mm-hmm.
Okay, Agnes Leslie is up next.
Thank you. Thank you for your talk, and especially thank you for your comments on colonial attitudes. And given that, I want to frame my question in the way that Africa is responding to the virus, at the continental level within the African Union, secondly, at the country level, and thirdly, at the individual levels. And I also note that at the beginning, we heard a lot of stories about countries like Senegal, for instance, coming up with their own creative equipment, like, coming up with ventilators. And also we heard stories about countries such as Tanzania itself, coming up at the individual level with ways of safeguarding themselves. And we also heard of countries like Botswana, for instance, closing down completely and making sure that people did not go out of their homes unless they had to. So I just want to find out from you what you think in terms of Africa standing up for itself and really saying we also can be leading in this status. We can actually take the lead in trying to actually safeguard ourselves at the personal level, safeguard ourselves, continentally, within the African Union, and also to that, what extent are they coming up and promoting, equipment, creative equipment like ventilators that we heard about at the beginning, and we don't hear about that anymore. I note that you talked about some countries having 5 ventilators, 10 ventilators. Couldn't some countries really do something about that? Thank you.
So that's a multifaceted question. I'll try to address what I can. And so the ventilator issue is a critical one because we know as COVID progresses and because there isn't a sort of effective treatment that exists right now, is mainly just providing oxygen to people and to make sure that they are breathing and monitoring them and fluid levels and other things like that. And so the need for critical care equipment is something that is acute. And there hasn't been sort of widespread sharing of critical care equipment, either regionally or sort of globally. And so that is something that you could think about there being a need for. I mean, I think that what has happened is that countries that can have tried to shore up their own national stocks of critical care equipment through procuring them on the market. But whether there is the need for sort of a pool or some kind of way in which those types of resources could be shared is definitely something that is important and necessary. In terms of whether, I think that the story is mixed, right? And so that's the kind of what I wanted to present in the talk. I think that there's some reason for, I don't want to say optimism, but I think there's some reason that you can think that there are strengths that can be drawn upon within the continent and within particular countries where there is the ability to draw on lessons learned, to draw on sort of local innovation and the like to deal with COVID-19. And I tried to present a couple of places where I thought that was happening, whether it's Senegal developing the rapid testing kits, or places like Ghana, where their industries have been converted to mask making or you know, there for a time was the delivery of, you know, using remote, what's the name of this thing? The remote drones, that's what it is. Using drones to help with, using drones to help deliver, go back and forth to deliver tests and also to take test results, particularly for dealing with roads that can be impassable and other things like that. So I think that there's definitely has been space for innovation that countries have capitalized on. At the same time, there have also been countries who sort of have a more ostrich approach, like Tanzania, in terms of leadership. And so, and there are places that we know where COVID is presenting a real challenge, like South Africa, which we talked about as well. And we don't know yet whether the story will be uniformly the same across the continent. And it doesn't make sense to think that it would be uniformly the same. And there are, you know, so many different countries within the continent, and those countries are structured differently. Some are more dense than others, some are more rural than others, some have more exposure than others. And so I don't think it makes sense to sort of try to paint a broad brush of what the story of COVID will look like. I think that there are spaces and places and opportunities for a drawing on lessons learned and being proactive. I think there are also places where there's you know, real concern about the lack of leadership at the national level, and also to sort of at an individual level, sort of a lackadaisical nature of thinking about the ways in which the disease impacts people's lives. And so the continent is diverse. The way in which COVID-19 manifests will also, I think, mirror that, and has been, in some sense, doing that to date.
Okay, I think at 4:57, and I don't see any more questions on the board, I'm going to say that we're officially out of time.
Okay.
I do want to put in a final plug for our upcoming live tweet Q&A session. You can tweet your questions to hashtag Sirleaf Baraza Q&A, and you can send that to @Africa_UF. And Professor Sirleaf will be there monitoring and answering your questions from 5 to 5:30, so another 30 minutes that we can continue beyond the webinar. So I'd like to really thank you for a great opening session for our semester calendar.
Oh, thank you guys for the invitation. This was great, and I'm glad I saw something go out that you guys referenced earlier, that this is one of the biggest audiences for Baraza, and so I don't want to take all of the credit. I know that COVID has allowed us to attract more people than would normally be in one space, but I'm grateful to have been part of this Baraza and to be in conversation with all of you. This has been really beneficial for me, and I hope that you gain something from the talk.
Thanks so much.